Welcome. In this video, we're going to be continuing to examine various aspects of the doctor-patient relationship by looking at one particular issue, and a very important issue that's prevalent for many of us, whether as family members or as healthcare providers. And that's the matter of the ethical challenges that emerge in the context of caring for patients with dementia. So here's the plan for today's discussion. I'm going to give a broad overview and discussion of the kinds of problems that often emerge when we're dealing with dementia cases. I'll briefly discuss a paper that was published in the Journal of Medical Ethics by Tarzia and her co-authors. We'll look at a case from Dunn and Hope, their case of Mr. Andrews, and this will lead us to some broader philosophical reflections on the nature of personal identity and the importance of well-being in our ethical decision-making, especially as it relates to patients with dementia. So let's think about how ethical challenges emerge within dementia care. Now, maybe one thing that we should talk about right at the outset is what we're talking about when we're talking about dementia. It's not just Alzheimer's disease. It's a broader umbrella term. Really, dementia is talking about a certain grouping of symptoms. So what kinds of symptoms? Well, it involves things like memory loss, difficulty in speech, difficulty in completing tasks, personality changes, and emotional agitation. So that's like a basic overview of what we're talking about when we talk about dementia. That's a definition we get from the Mayo Clinic. Now, Dunn and Hope say, when we're caring for patients dealing with these kinds of symptoms, there are a number of potential dilemmas that might emerge in that person's care. So for instance, there might be a way in which we need to balance, on the one hand, freedoms of the patient versus risks. So a patient might put themselves at risk of physical injury without constant surveillance. When we're talking about somebody with memory loss and who suffers from difficulty completing tasks, this might involve, for instance, not allowing a patient to cook in their own apartment. Right? We could imagine somebody with a certain amount of memory loss deciding to make some hard-boiled eggs, putting some eggs in some water on the stove, and then letting that water boil off over the course of an hour. And next thing you know, smoke alarms are going off as these eggs are being burnt at the bottom of an empty pan. Right? And because of this, we have risks of physical injuries to patients, and we might worry that we might have to take away resources or options from dementia patients. And some people tend to think that there's a need for constant surveillance. It's also often noted that there's a concern about whether doors are left open in residential aged care facilities. On the one hand, there seems to be a need to have access to the patient at all times for their safety, but on the other hand, this is coming at the cost of this patient giving up their privacy. We can also think about how the interests of various parties might be balanced. Dunn and Hope have us consider a case of a patient who, through emotional agitation, might spend much of the day shouting or expressing an extreme amount of agitation. That might bring discomfort to the other healthcare workers or other patients. And one option that may be considered would be sedating that patient. But on the other hand, we might think that that would be an unfair thing to do to a patient simply for the sake of making everybody else more comfortable. We can also ask questions about deception. So if you have a patient who is resistant to taking their medications, would it be okay to put that patient's medications into their food? You know that this patient will always finish their applesauce, so why not put their heart pressure medication or their blood pressure medication or any other number of things, into that applesauce? So that might be a certain kind of deception. Another kind of cousin of deception, lying. That's deception where you're intentionally saying something false to a patient. Well, should we lie to a patient who can't remember that their spouse died? And we might know through experience that in previous instances, when we tell this patient that their spouse is dead, they will be distraught for much of the day because of it. There might be a situation in which healthcare workers might tell a lie. They might say, oh, he's nearby, or they might say a half-truth, right? I haven't seen him lately, but you might be seeing him again. If you believe in the afterlife, maybe that doesn't quite count as a lie. But there are all sorts of questions of, how do we respect the freedom, the interests of various parties? Do we have a right to deceive or lie to patients with dementia because of how difficult giving them the truth directly might be? And because these cases are prevalent and a real problem for how we're going to care for a patient, we actually need to realize that this is a way in which ethics is simply needed within healthcare. Right? These problems emerge naturally, and a clinical ethicist can be brought in to help guide conversations and help everybody on staff or help family members who are involved in the care of a person with dementia. A clinical ethicist can help to guide these conversations. Here's one example of maybe an interesting challenge that we've seen from clinical ethicists and medical ethicists in recent years is policy has been changing as it relates to sexual expression in nursing homes. The old model of nursing homes often had a almost militaristic way of arranging itself, right? People were expected to wake at a certain time, eat at a certain time, engage in certain activities at a certain time, be in bed at a certain time. Many nursing homes have been moving away from that, or as Tarzia and her co-authors refer to them, residential aged care facilities. So in past residential aged care facilities, it was common to have policies that were designed to discourage sexual expression among residents. And we might think of this as sort of a continuation of that militaristic model. But Tarzia et al. Point out that this is hardly a good way to show respect for patients. The ethical outlook that they hint at towards in this paper is what they call a person-centered ethical approach. And the thought is, if we're taking a person-centered ethical approach, we need to, as far as we can and whenever possible, respect the dignity of each patient. Right? Now, in that context, they're going to say, well, when it comes to sexual expression, that's a human right. Just as it's a human right for people who are young and people who don't have dementia, well, simply getting older or developing dementia does not restrict a person from finding dignified ways to pursue sexual expression. And maybe here's the controversial or interesting idea that Tarzia and their co-authors point out. They're going to say that the capacity to consent to sexual activity should be presumed in patients at residential aged care facilities. The idea being that we shouldn't, as a matter of course, say that anyone who is in need of care, or even anybody who's beginning to show symptoms of dementia, we shouldn't simply say, oh, well, this person is no longer qualified to pursue sexual expression, and we might take a paternalistic approach, right? Try to make a decision for them for their own well-being, to say, we're going to take away certain options of yours preemptively to protect you. An important thing to note about dementia is that it is not an all or nothing kind of situation, right? We can talk about early, moderate, and late stage dementia. And the ability of a patient to understand what's happening to them and to express their wants is still significant when we're talking about early and even moderate dementia. And in this way, Tarzia and their co-authors are going to say the capacity to consent to something is context dependent. Here's how they put it. They might note that a patient with moderate dementia might not have the ability all on their own to consent to a risky surgery, right? So if we are talking about a surgery for a patient, which might be aimed at removing a certain cancerous tumor, a patient might no longer have the capacity on the basis of their dementia to do that, to make an informed judgment about whether the risks of the surgery are worth taking on. But Tarzia et al. Also point out, even if that's the case, we would still give a patient in that situation the option to choose what flavor of ice cream they're going to eat after dinner, right? So it's not as if, as soon as you lose your ability to consent to a surgery, then you don't have any say over whether you're going to eat chocolate or strawberry ice cream. And here's the point that Tarzia et al. Are going to make. They're going to say that patients, even if they have verbal communication problems, they might still be able to express preferences. So facial expressions, moving towards things, moving away from things, shaking their heads yes, shaking their heads no. In the right context, these sorts of nonverbal cues, that is, cues that go beyond just the words coming out of one's mouth, might be able to say a lot about a person's preferences and may even constitute consent or dissent in certain situations. Now, an important thought that Tarzia et al. Are advancing is that when it comes to sexual expression, in many ways, it's more like consenting to or asking for a certain flavor of ice cream than it is consenting to a risky surgery. That sex, when done right, does not lead to any major health risks, and can also add to a patient's level of happiness and flourishing. And we might say that even if a patient has lost a large amount of their verbal cues, their ability to use words, Tarzia et al. Say we should be open to the possibility that a person with limited verbal capacity might still be able to engage in certain forms of sexual self-expression, having sex with another patient in the facility perhaps, even if their verbal abilities are limited, so long as we are taking seriously their nonverbal cues, their body language, what they are happy about, what they move towards, what they move away from, the facial expressions they make, what they say, what they nod yes to, what they nod no to. And in this way, it's going to suggest that consent, capacity, is not an all or nothing concept. We actually have to be respectful of context, and we might even recognize that even if a patient can't consent to some things, like surgery, they might be able to still consent to other things, like ice cream flavors or sexual activity with another resident. So that's like one way in which medical ethics might have something to say about the care of patients dealing with dementia. Here's another case, and this is a case that comes out of our book From Dunn and Hope. So here's the situation. They say it is close to Remembrance Sunday. So Remembrance Sunday is a day in Commonwealth countries, that is, countries connected to the United Kingdom, where we commemorate the contributions of military servicemen and women in the 2 world wars and subsequent conflicts. A war veteran comes to a residential care facility selling poppies, and this is a flower worn to commemorate the occasion. In my home country of Canada, these poppies are also worn during Novembers in order to honor the military contributions of veterans. So the staff decided to organize an activity for residents in the main lounge on Sunday morning, including watching a service for Remembrance Sunday on television. And the staff knew that we had some veterans living in the facility, and they thought that this would be an event appreciated by all. And on the Friday before the service, the daughter of a Mr. Andrews, one of the residents, visited her father and was shocked to see him wearing a poppy on his jacket. Because Mr. Andrews' daughter tells Anne, one of the nurses, that her father had been a conscientious objector all his life. A conscientious objector being a certain kind of person who is morally opposed to war and who, on that basis, opts out of certain traditions commemorating military contributions of others. So his daughter says he would have been mortified if he'd known that once he got dementia, that he would end up in a care home wearing a poppy and watching a Remembrance Sunday service. So Anne, the nurse, removed Mr. Andrews' poppy and told the other staff members that he was not to join the group activity on Sunday. And Anne felt that this was the appropriate way of respecting Mr. Andrews. But on the Sunday of the Remembrance Sunday service, another staff member gives Mr. Andrews a new poppy, encourages him to join watching the Remembrance Sunday service. The other nurse, who dealt with Mr. Andrews' daughter, Anne sees what's happening, removes Mr. Andrews' poppy, leads him to the lounge, and at this point Mr. Andrews is upset. He's now attempting to grab the poppy back and to go back to the lounge. And other members of the staff had strongly expressed their views that Anne had acted wrongly in causing Mr. Andrews distress in this way. And since then, Anne had slept badly, worrying about whether or not she had acted correctly. A really tough and interesting case. On the one hand, we might see exactly why Anne was trying to remove Mr. Andrews from the service. On the other hand, upon seeing the agitation of Mr. Andrews trying to grab the poppy back, trying to go back into the lounge, we can also see why the other staff members were in disagreement with her about her choice. So this is one of these cases where a medical ethicist, somebody working in a clinical context, could make a meaningful contribution. Part of what the medical ethicist will do is help facilitate a conversation that helps disagreeing parties come to an understanding, not only about the different points of view on the table, but also about what might be done about the situation. And a big question that's going to come out here is, well, how do we respect Mr. Andrews' wishes? Are we to respect the wishes of Mr. Andrews before he got dementia? Or do we respect the wishes of Mr. Andrews now, who's trying to grab back the poppy and who's trying to go back to the lounge with his friends? And if we get deeper into this question, and we're asking the question, what did Mr. Andrews really want? We can even ask the question, is Mr. Andrews the same person he was before? Now, when we start asking this question, am I the same person that I was 10 years ago? We're really beginning to make philosophical assumptions, even if we don't realize it, right? Because our answer to the question, is Mr. Andrews the same person he was before? Depending on what you say, you're going to commit yourself to different approaches to the philosophical question of personal identity. So, personal identity is not about whether you're different in some qualities over time, right? So we can talk about how people change qualitatively over time. So sometimes I have a sunburn, sometimes I don't, right? Sometimes my hair is long, sometimes my hair is short. I pretty much have a beard all the time nowadays, but there was a time in my life when I didn't have one, right? So it's true that our qualities change, but we can still ask the question whether those differences in qualities are enough for you to count as an entirely different individual. So for instance, if I were an entirely different individual than I was 5 years ago, well, then we'd have to ask all these questions about whether I should have access to the money that I deposited in my bank account more than 5 years ago, or whether my marriage certificate is still valid, or whether my PhD still counts, because it's been more than 5 years since I earned my PhD now, right? So we can say, like, look, there have been changes in myself as a person, but we would think that there is some sense that even though certain qualities about me have changed, most people tend to think that I'm still the same person I was, say, when I was granted my PhD, or when I put some money in the bank, or when I got married, right? So part of what we have to do here is figure out, well, what is it about me that makes me myself, right? And here is a popular answer. This is probably the most popular answer in various ways in both philosophy and in common discourse. We're going to say, well, it's not your body that makes you yourself. Even though it's not exactly true, people will point out that pretty much every cell in your body will get swapped out after a certain amount of time. The majority of your body weight will be replaced. The water molecules in you now might not be the water molecules in you a year from now. Your skin is always changing. Even the composition of your bones is going to change, although more slowly. And we're going to say, instead of your body, what makes you you is your mind, right? So we can say, for me to be me is to have certain mental states, such as beliefs, intentions, memories, and emotions. So we might say that the reason why the PhD that I earned over 5 years ago still applies to me, this guy in this room, is because of certain facts about my mind, right? I still remember many of the things that I learned in graduate school. And I'm still continuing certain projects that I began in graduate school as a teacher and as a researcher, right? And we might also think of my beliefs and intentions and my memories as continuous. We might even say that, look, even though Many of my cells in my body have changed out over 5 years, or 7 years, or 30 years. We might say that in my temperament, there are a lot of ways in which I'm still very similar to the person that I was when I was 8 years old. And I remember certain things about my life from when I was 8 years old. And in this way, we can say that my psychological states are continuous. And this continuity is a way of explaining how I can stay myself over time, even though many of my qualities change, and even though my body is always changing. Now, if we take this view, the psychological continuity view, we might notice, for instance, that some members of the staff might say, Mr. Andrews is no longer the same person that he was before. If we can talk about young Andrews, the anti-war protester who would have detested attending a Remembrance Day ceremony and who would have never worn a poppy, well, you could say there just isn't much continuity between that young Andrews and older Andrews with dementia, who now wants to wear a poppy and who now wants to attend a Remembrance Sunday service. We might say that's a way in which he's no longer the same person that he was before. And in that way, the wishes of his previous self don't really apply to his current self. Now, we might start to ask the questions. It might be the case that these preferences and these motivations change, but what if, and I think that we get a little bit more information about the case in our textbook from Dunn and Hope, where they suggest that, well, maybe Mr. Andrews can still reminisce about the old days a little bit. We're still left with a really head-scratcher of a question, which is the question of, well, how different does Mr. Andrews get to become before he has to be considered a new person altogether, right? So when people on the staff say, Mr. Andrews is not the same person that he was before, the medical ethicist can come in and point out that this is an approach that many philosophers take and many people take. And we might need to be mindful of how this approach to psychological continuity is highly important for understanding what makes you you. And it also helps us raise questions about how to deal with people whose psychological continuity is breaking down in various ways. But, we might say, this view misses something. Our nurse named Anne, who was trying to respect the wishes of young Mr. Andrews and the wishes of Mr. Andrews' daughter, might take a different approach. So, what our textbook calls the situated embodied agent account says, look, we are not just constituted by a series of memories or a pattern of emotions, right? The situated embodied agent account is going to say, look, your life is not lived in a vacuum, but it's lived in relation to other people. Humans are social beings, after all. So to be yourself is to be connected to a particular body, but it's also to have a self constructed by yourself and others. So if we're asking the question, what is it for me to be me? It's going to put less emphasis on something like memory, and it's going to put more emphasis on things like the roles we occupy in life, right? So I can think of the roles that I occupy in life as being, well, I'm a son and a husband and a brother. I'm also a teacher and a friend to some people. We might say those are the relationships that I constitute through my self-perception and also how I relate to other people. And we might say that the relationships that constitute Mr. Andrews are still there even when his memory and his psychological continuity begins to falter. Right? So we might say, he is still Andrews, the same guy he was when he was young, because of the relationships that he stands in, say, with his daughter. And in that way, we might say, even though his mind has changed a great deal, the relationships that he stands in are still largely the same. And that's a way in which we say he really is that person who was the conscientious objector, the anti-war protester. But after these views about personal identity are exchanged in the context of Mr. Andrews, at least in this hypothetical case, Dunn and Hope have us consider the possibility that the conversation might take a further step. Right? We might say the question of whether the wishes of Mr. Andrews' younger self are the same wishes that apply to his older self, whether he's the same person or not. We might ask questions beyond personal identity as well. So we might ask questions about autonomy and empowerment, and we might say that these questions of autonomy and empowerment might be more about how we give Mr. Andrews control over his life. And even beyond the question of control, where we're asking about whether we respect his previous self or his present desires, a further question might emerge, which is the question of respecting prior wishes, control over your current desires, or we might also ask about promoting well-being. And we might even say, even though we want to have a certain amount of respect for the prior wishes of this man, we might also ask questions about how we can look after the well-being of this patient in the here and now. And we might say that even if Mr. Andrews expressed anti-war views very clearly in the past, we might realize that if it comes at too much of a cost to Andrews's well-being, that might require flexibility. That might require, say, allowing him to wear his poppy and allowing him to attend a Sunday service that his prior self might have objected to. And we do that on the basis of sort of setting aside questions of prior wishes versus current desires, and instead we focus on how can we find a situation that works for the patient in the moment. So I hope that shows how dementia is a great invitation into seeing the importance of medical ethics, right? Because these are problems that are going to emerge whether we like it or not. And medical ethics can give us the tools to navigate and collaborate on solutions to the disputes that might emerge. So, thanks for listening in. We looked at some work from Dunn and Hope. We got that definition of dementia from the Mayo Clinic. And we also heard about how maybe when we think about giving patients control, dignity, and well-being in their lives, that means not necessarily having restrictive policies when it comes to things like sexual expression. But as we can see, dementia brings a great many ethical challenges in the context of healthcare. And this has been just a brief invitation into some of the ways in which those problems can emerge. So thanks for listening in, and take care.